This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. We're delighted you're with us today. And sometimes we talk to Red Cross, sometimes we talk to Carter Blood Care about the importance of blood donation. But we thought we would really go and talk to some of the people that work and deal right on the scenes. And we couldn't have a better person than Jason Piecek with us today. He's an Air Medical Base Supervisor and a flight paramedic at PHI Air Medical. Welcome to the show, Jason.
Thank you for having me.
Let's just begin to help our listeners comprehend why is it so important that people donate blood?
Well, there's quite a few reasons, but I'll kind of stick to some of the broader ones. I think most importantly is people have to remember that blood is a perishable product, meaning it doesn't have an eternal shelf life. Some parts of the blood are only good for as long as 5 days, like the platelets, but a month or less is the shelf life for pretty much all blood products. And again, some even shorter than that. Second to that is just the supply and demand in general. Every day, almost 30,000 units of blood products are administered throughout the U.S. And if you think about that, that's pretty significant when you think about the needs. Today we'll talk primarily about the trauma and that side of blood administration, but there's also a huge need on the medical side, especially for like cancer patients or people with blood diseases. But another benefit that a lot of people aren't aware of is there's actually personal benefits to the people donating as well. First, obviously, you get to give the gift of life potentially with the blood you're giving, but also there's health benefits associated with it. It helps thin out the viscosity of your blood, which is valuable, especially for some people on certain hormone replacement. If you have really high iron levels. And you also get essentially a free mini health screen. They're going to, run through some questionnaires with you. They're going to take your blood pressure, your heart rate, and then, shortly after you give the blood itself, they actually run tests on the blood, and you'll get a little blood report back that'll give you, your lipid panel, your CBC report, and it scans for some infections as well. So quite a few different benefits on why you should donate there.
You made a really good point, especially on the benefits to the donor. When you get that little report back, it's done in a real confidential manner, isn't it?
Correct, yes. A lot of places nowadays with the digital age, you'll basically get a login, and you can log in and look at it yourself. So it's easy access and secured.
You mentioned that certain parts of the blood you have to use frequently and they're different components. Can you expand a little bit for our listeners on when they make a blood donation, what are just some of those other components that can be used?
Like I said, there are quite a few products, and I'll stick to the main ones. There are a few specialty ones, but in general, you have whole blood, which is used a lot more in trauma, and it's probably the most ideal for trauma. Not as common. Usually it is broken down into different pieces. Then you have the packed red blood cells, or the red blood cells. You have whole blood itself, which is the entire blood just as you donate it. That's used a lot more commonly in trauma. And then as far as when they break it down and separate it, you have the red blood cells, which is what gives blood, its reddish color. That's what carries oxygen around the body. You also have plasma, which is the liquid portion of the blood. And the red blood cells and plasma together make up essentially almost your entire blood volume. And plasma also carries some of the clotting factors. It also carries proteins and stuff like that. And then the smaller pieces, you have the platelets, which are for clotting. They are also given to cancer patients as well. Your white blood cells, which is what helps fight infections. And then they also sometimes break it down into what we call cryo, which is super concentrated clotting factors is what that is.
You know, when you think in terms of blood and blood administration, and you mentioned in the medical setting in hospitals with cancer patients, et cetera, but I often think about, once I was talking to a lady that was involved in a serious car accident, and of course the EMTs responded and the paramedics and got her to a level 1 trauma center. And she was in a coma 2 weeks, but she survived, did rehab, and did well. And she thanked the trauma doctor at the end of her treatment saying, "You saved my life." And his response was, "No, the paramedics saved your life." And the reason I'm giving that preface, do you administer blood in the field?
Yes, we do carry blood products on the aircraft, and most of the air medical providers in the DFW area do carry it as well. We're starting to see it some on the ground ambulances as well, carrying it, which is amazing because, as you referenced her story, there are other stories like that as well, where blood administration early on truly does make the difference between life and death. You know, years ago, you didn't have that option. All you had was fluid, to administer to replace that volume, which is great for volume replacement, but it doesn't, supply any of the things we just talked about. You don't get red blood cells, you don't get plasma, so you don't have the clotting factors and the ability to carry oxygen, which is vital. When you're losing all that fluid, you end up in a shock state, and oxygen ability and all that is affected by that. So the ability to administer that on scene really stops the clock for that trauma patient and improves their survivability rate.
When you think in terms of what you just said, that you're beginning to carry blood products not only on the ground but in the air, how do you manage that when, as you mentioned earlier, some of the useful life of it expires quickly?
There's a few different ways, and different providers are going to have different contracts, I guess is the best way to say, of how they procure their blood. So what we try to do is obviously use it, but if it's not used, we try to rotate it back into either the blood bank or the hospital system we work with, so that way it can be used and it's not gone to waste. And then in the North Texas area specifically, we're in the very early phases of creating a regional blood program where we'll be able to rotate it through hospitals and multiple different providers. So it's even more readily available to EMS, and it will also ensure there's a stockpile should any mass casualty ever occur. There's a stockpile ready to go.
We're talking with Air Flight Paramedic Jason Piecek about what happens to blood after we donate. Have you ever given blood? Or does the thought of giving blood make you a little squeamish? Well, I'm going to ask Jason about that, and maybe his answer will make you a little bit more comfortable giving blood. That's next on the human side of healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
We're continuing our conversation now with Jason Piecek, who is an air flight paramedic, about that always very important community-related human side of healthcare issue of donating blood.
To our listeners out there, do you have advice on where they can donate blood?
Up here in North Texas, there's the two main people are Carter Blood Care and the American Red Cross. So either one of those, they're pretty easy to find on the web. You can go. Sometimes you'll see them set up with a bus outside of buildings. If you have a company or a community event or a school, you can speak with them and they can come out and actually set up a blood drive for you. The process itself, from about the time you check in to the time you leave, is probably around an hour. The blood draw itself doesn't actually take that long, but as I mentioned before, they're going to do a little bit of health screening and stuff as well. As kind of a general rule, about every 2 months you can donate. It depends on, what exact type of donation you're doing, but roughly about every 2 months. And then between blood banks, it varies a little bit, but for the most part, as long as you're 17 or older and you weigh over 110 pounds and you're in good health, you are eligible to donate. And if you happen to know your blood type and you are O blood type, that is probably the most ideal, especially if you're O negative. That's the universal donor that they can pretty much use for anybody.
Thank you so much, Jason. Thomas?
Jason, why do I always pass out when I'm giving blood? I am 62 years old. For all of my life, bonk. And I'll tell you why I'm asking is somebody told me just the other day, I was talking about this, and they said, well, your body feels like it's in trauma. It's losing blood, so it starts to shut down. Is there any truth to that?
It's funny you say that. My wife is one of those people, so I very much understand what you're talking about. I'll be honest, I'm not sure if that's the true factor behind it. There could be a few reasons. Before you go donate, you definitely want to make sure you're well hydrated. You've eaten that morning. You've had a good meal, and you're in good health. Reason being, if you go in there dehydrated and malnourished, they're taking some of that blood out of your body. And when that happens, sometimes afterwards with that amount taken out, you'll stand up and you end up passing out. You get lightheaded as that fluid shift changes from sitting down to standing up. Another reason is, I'm sure you've heard just in general, even when people go to the doctor's office to get a simple tube of blood drawn, they have an exaggerated, I almost want to say psychological, but I guess it is a physical response, and it's what we call you vagal out, and you end up passing out. It's not life-threatening. You'll regain consciousness pretty quickly, but some people do have that that reaction, and the best way to mitigate it is to ensure you're well hydrated and you're well nourished before you come in and in good health. You're not sick or got anything like that going on.
And then everybody says it's good to have something like they keep orange juice or crackers or some kind of snack. I guess you could bring your own, right, for afterwards? Sure.
If you have a preference, I'm sure you could bring your own. But yeah, they always provide you some sugary drinks afterwards as well. And that the reasoning behind that is that kind of helps to offset that effect.
Now, you mentioned that you can give about every 2 months. Why is that? Why 2 months?
And that 2 months is just kind of rough if you're giving traditional blood. There's different types of blood draws. You can give just plasma, or you can give, blood in general, which is what most people do. And reason being is it takes your body a while to regenerate some of the pieces that it lost. The fluid part, it adjusts for pretty quickly, but your iron levels and stuff take a little while to regenerate to the necessary levels to donate. If you're just donating plasma, you can actually donate a little more frequently than that.
What is the least amount and most amount of blood that you can donate or that they will accept?
In general, you donate about a pint. And I'm actually glad you brought that up. I forgot to mention that in the beginning, that for every pint you donate, that equates to about 3 units of blood product. So that 1 pint ends up getting broken down into 3 units of blood product. And typically that's what they're drawing. They do have some processes where, and forgive me, I forget what they call it, where they do take off more than that. But the donating requirements for that are pretty stringent. They're a lot more stringent than just your normal donation. But in general, they take about a pint of blood. And the human body, on average, is somewhere around 10 pints of blood.
What final thoughts do you have for our listeners?
Yes, please, if you fit that category and you are eligible for donation, please get out there and do it. You never know whose life you might be saving. It sounds like there should be a ton of people that fit that category, but in real life, if you look it up, less than half the people in the U.S. are actually eligible to donate. So if you have that ability, please get out there and donate. Donations you tend to peak after big tragedies. But the problem is, when that tragedy actually occurs is when we need it immediately, and we need a stockpile ready to go. During the summer months and winter months are when the shortages tend to be worse. So if you can get out there, please donate. You're doing a great service for your community and for humanity in general.
Great tips and advice from Flight Paramedic Jason Piecek. And thank you, sir, for your service to our country as well. We're going to shift gears now and talk with Dr. Christopher Cottrell, General Surgeon at Medical City Frisco. You ever eat something and have that off feeling in your gut? Could be GERD. What is GERD? We're going to talk about it. Steve?
To kind of set the stage, even though it does affect or impact 20% of Americans, what do you define as GERD?
It's simple. Basically, when contents from the stomach come up into the esophagus, the definition, gastroesophageal reflux disease. So going from the stomach to the esophagus, gastro, and then to the esophagus, that's what it is. It's just contents from the stomach coming up into the esophagus. The interesting part is that people often equate that with heartburn, and heartburn is more of the symptom. It's what people feel. It's the burning that you feel from the acid. And so that's kind of where people confuse that a little bit, because they say, I have heartburn, and they kind of think of that more of the disease. And to me, that's always more of the symptom of the gastroesophageal reflux, and probably the most common symptom.
I mentioned 20% of Americans experience this, but from your professional opinion, how common really is it, and who does it generally impact the most?
The longer answer is, at some point, probably nearly everyone, right? I mean, I kind of talk with my patients, if you have enough pizza or spicy things and drink enough beer, everyone's going to have reflux at some point, right? So most people in their lives, they have a little upset stomach, they take Tums, they get better. But in terms of people that it chronically affects and starts to affect their lifestyle and quality of life, it's kind of more in that 20, maybe even 30% of patients. And people deal with that in different ways. So who it affects, I think it varies. It's commonly seen when we have conditions that increase intra-abdominal pressure, which makes it easier to reflux. So we see this commonly during pregnancy, for example. When, the uterus expands, as the fetus develops, it takes up more and more room inside the abdomen, therefore more intra-abdominal pressure, easy to reflux. So then late in pregnancy, it's not uncommon for women that are carrying to term end up having reflux and have to take, Tums or some sort of antacid to get through that. So we see that also with, obesity. As we gain weight, that intra-abdominal pressure increases. So definitely those two things, but it doesn't mean you have to be obese or pregnant to get reflux or symptomatic reflux that bothers you. Anyone where somehow the barrier to reflux breaks down can get reflux. So it doesn't necessarily require intra-abdominal pressure.
You mentioned obesity and pregnancy and maybe eating too much pizza and drinking too much beer and spicy foods. Are there other common causes for GERD?
I think the most common cause that at least it ends up we kind of proceeding to surgery with is a hiatal hernia, right? So when we talk about the reflux barrier, a lot of it has to do with the relationship of where the esophagus is in the abdomen. And so when the esophagus is below the diaphragm, meaning that it's in the abdomen, then that positive pressure will kind of squish, for lack of a more medical term, the esophagus, and that helps prevent reflux. So when that breaks down, when you have a hiatal hernia where the stomach is up in the chest and we have no esophagus below the diaphragm, then you can start to see reflux, right? And so restoring that anatomical relationship often will help reflux.
You mentioned heartburn as a symptom. What about acid reflux? Is that similar to GERD?
It's a synonym for sure. Yeah, acid reflux just refers to that the contents of the stomach are usually acidic. So, pH of, in the 2 to 3 range. And so, yeah, acid reflux just is the stuff from the stomach that's acidic into the esophagus.
A lot of us deal with GERD, and it is uncomfortable. More with Dr. Christopher Cottrell, a general surgeon at Medical City Frisco, next on the human side of healthcare.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're continuing our conversation with Dr. Christopher Cottrell, a general surgeon at Medical City Frisco, about esophageal reflux disease, GERD. And particularly, Dr. Cottrell, when does it become a genuine, serious medical issue?
I think the little bit longer answer is anyone that has had long-standing reflux at least needs to be evaluated, right? We want to look for things that then become more serious. So we're looking for erosions and esophagitis in the esophagus that are signs that this reflux is pretty severe and actually is causing injury to the esophagus. And that's important because as that esophagus gets injured, your body's natural responses to the lining sort of changes itself and then, take a couple steps down the road, and that can actually become a precancerous lesion. Now, that's not to say that everyone that has reflux is, at high risk for cancer. That's not true. But, that's the pathway, erosions, then something called metaplasia or a change in the lining, and then on to dysplasia, which then is, kind of more on the cancer spectrum. So fortunately, those rates aren't super high, but it is something you want to be looking at and you want to be screened for if you've had long-standing reflux.
When an individual comes to visit you, what type of test can you use to, evaluate GERD?
That's evolved over the years for me. Basically, we do an endoscopy, and that's where we're looking for any of that damage, any of the anatomical problems like hiatal hernia. At the same time, we do something called a Bravo pH probe. A Bravo pH probe just literally measures the acid in your esophagus. So we can put an objective number on your acid reflux. And then the last thing is, and this is more like a preparation, because the people that are, undergoing this endoscopy are, considering surgery. We want to see how well the esophagus contracts. So we do something called an endoflip, which basically sees how well the esophagus contracts. And that helps guide what type of surgery we can offer.
So if someone is diagnosed with GERD, and I'm sure there are different degrees of it, what treatments are available?
The first ones we've kind of touched on with the pizza and the beer and obesity and things like that. So lifestyle modification. If you've got mild reflux that's not greatly affecting your life and there's things that you can easily change, lifestyle modification is a great first point of view. So, not eating as much spicy food, cutting down on the alcohol consumption, losing some weight can make a big difference, particularly early on. Avoiding the acid reflux trigger foods and spicy, beer, stop smoking for sure, but also certain things that you wouldn't necessarily think of, like acid containing foods like lemonade and tomatoes and tomato-based foods, things like that. Peppermint, chocolate, coffee. These are all things that can kind of make the acid situation worse. So avoiding those foods, losing some weight, lifestyle modification. Once it gets past that, if you're still having symptoms, even though you've made the lifestyle modifications, or if you just can't, right? If that's just part of whether it be your culture or heritage or something you're not willing to do, then we have to talk about medication, right? Medication is probably the next step where we put patients on things that reduce the acid level in the stomach. So while they still may have reflux, stuff that comes up, it's no longer acidic, so it doesn't burn. These are things like the proton pump inhibitors, H2 blockers, and the like. And that does a pretty good job at controlling heartburn type symptoms. So dietary modification has almost no side effect, right? That's pretty simple. So if someone can lose weight and that's appropriate, and if they just don't love Italian food and spicy food and they can make that modification and that helps them, there's not much side effect there. Patients that consider surgery, which would be the last step, is someone who either can't take medication because of some sort of reaction, or they don't want to take the medication because all medications have at least some side effects. And we don't fully know the full effects of all these proton pump inhibitors that people take. And so people that don't want to take medications or are breaking through, like they have symptoms even though they're on good medication, those are people that we consider surgery. And so with surgery, there's, controlling the hiatal hernia that we talked about earlier, some sort of, it's called a fundoplication, and that just means some sort of valve or wrap that we construct out of the stomach to not only, having the esophagus below the diaphragm, but also creating a valve that prevents reflux. And that kind of the belt and suspenders, controlling the hernia, creating a valve with a surgery procedure.
We've been through a lot the last few years. We have interest rates going up. We have inflation, etc. People are under stress. Does stress impact GERD?
I am far from a holistic type doctor, but I'd have to say that stress plays a role in almost every disease process, right? And so they've actually looked at this. When you are under a ton of stress, it changes your hormone levels, it changes your cortisol levels. And these are all things that play a role in your whole body. So any type of stress can affect any medical condition. Furthermore, we know that, the stress, depending on how much it is, whether it be physical, emotional, or otherwise, that actually can increase the acid levels in your stomach. So it can directly affect it, in addition to kind of the more holistic approach of it, stress affecting much of everything. So absolutely. Matter of fact, there are things called stress ulcers in the stomach caused by the acid production under stress. Now, typically that's in patients that are quite sick, in the intensive care unit. And we've learned how to manage that a lot better. But stress is definitely a prime issue with acid production.
This is The Human Side of Healthcare. We're talking with Dr. Christopher Cottrell, a general surgeon at Medical City Frisco, about GERD, or esophageal reflux.
For people that smoke, how does that impact GERD?
The quick answer is negatively, right? Smoking has all kinds of adverse health effects. So there's no question and not any reason I could think of to not recommend quitting smoking. So definitely, if you smoke, you should figure out a way to quit. That being said, specifically with reflux, the area that is the anti-reflux barrier just relaxes. And so basically, it just makes it worse. Furthermore, with regard to the progression to disease and cancer and things like that, that just increases that risk. So esophageal cancer risk, the two biggest ones basically are smoking and reflux. So you combine those two, and it's a bit like gasoline and matches. They just don't go well together.
I know each person's different, but based on patients you treat, when you have an episode related to GERD, how long does it generally last?
That is definitely a wide spectrum. I have patients that have several small episodes every single day. I have people that generally don't have a whole lot of symptoms, but then have these longer episodes. So unfortunately, that's hard to pin down because everyone experiences this differently. Sometimes it's just short and ongoing all day. Sometimes it's longer episodes. Sometimes it's kind of 24/7. So unfortunately, it's a wide spectrum. But people that are seeking treatment, it's generally more often than not is maybe a bit of a hedge.
So, if someone has been diagnosed with GERD, as they deal with not only their physician, but other medical professionals, why, in your mind, is it important they discuss this with their physicians?
Long-standing GERD has the potential to cause esophagitis, erosions, and things that can become much more serious to include cancer. That's something that we need to be knowing about. Don't just be taking Tums or Pepto-Bismol or something at home that is just helping your symptoms without at least having it evaluated with an endoscopy at some point. Now, that's not something that we have to do every single year or anything like that, but generally a screening just to see where you're at. Because even if you are happy on medications or not considering surgery, or it doesn't even bother you enough to take chronic medications, it is something you want to make your doctor aware of so that your doctor, primary care doc, GI doc, surgeon, whatever, can make a determination of whether you're appropriate to be screened.
Let's say you experience GERD. Can it be permanently cured?
Cure is a great point of discussion because without surgery, the answer I would say is basically no, because medications control the symptoms and they control the acid. Fundamentally, this is an anatomical problem, right? So when the relationships that control reflux are breaking down from hiatal hernia and whatnot, unless you correct those, then you really can't affect cure. Now, again, we talked about pregnancy and obesity, and if you have GERD related to those and you control your weight or give birth, then yeah, we can sort of have that in remission or cure, whatever you want to call it. But if you don't really have those as part of the factor, you've got to control the anatomical problem. So surgery can affect a cure. And those rates depending on which study you read, are sort of in the 80 to 90% effective at controlling reflux for a long period of time.
Based on your experience with your patients, and especially for our female listeners, let's assume that during their pregnancy, they do have GERD and they come to you for treatment. And then after the pregnancy, let's say a couple of years later, they expand their family again and get pregnant again. Does GERD generally repeat in subsequent pregnancies?
That is a great question. And I think most women will tell you that every pregnancy is different. Things get carried a different way, whether you carry more anterior or posterior or low, high. And I've had women that said, I got a ton of heartburn with my first pregnancy, but not the second, and vice versa. So I think if you're prone to get it, yes, you're more likely to get it, but it's definitely not a sure thing, because I think as most women that get pregnant would tell you that each one's a little different. With other things too, including nausea and, swelling and all the things that pregnancy affects. So no two are identical, but it would make you more likely to have it, yes.
Dr. Christopher Cottrell, a general surgeon at Medical City Frisco, talking with us here about gastroesophageal reflux disease, or GERD. Dr. Cottrell has his own podcast too, by the way. It's called Dr. Chris, the Surgery Guy. And you can catch this entire episode on our podcast, The Human Side of Healthcare, and on our YouTube channel under the same name. More with Dr. Christopher Cottrell next on The Human Side of Healthcare.
Covering the healthcare topics that matter most to North Texas. This is The Human Side of Healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're continuing our conversation with Dr. Christopher Cottrell. He's a general surgeon at Medical City Frisco, has his own podcast, Dr. Chris, the Surgery Guy, and we're talking about GERD, or gastroesophageal reflux disease. And Dr. Cottrell, I got to tell you, I'm one of your 20%.
Yeah.
And it
I'm
hit,
sorry.
yeah, I thank you. Maybe a future patient here that you're talking to. It hit me in my 50s, and
Sure.
I remember my dad had it, and he called it the henthorn stomach. Can genetics affect it?
Yes. Now, we don't have a great model for the cause of hiatal hernia. Patients all the time, and I see lots of super educated people that they want to know why. The why is very, very important to them. And I don't have a great answer, because, when the hole that is in the diaphragm that allows your esophagus to pass from the chest to the abdomen, when it gets too big, that's when you get a hiatal hernia. And what makes it too big? It's a question we don't have the answer to. Certainly there's some genetic component to it, like everything, but it's not the same as eye color or hair color or skin color that, we can directly look at genetic inheritance patterns. So definitely tends to run in families, but not as good as, say, eye color or other things.
And then when you get a sudden onset there, like weight didn't change. I've pretty much been consistent, the same weight most of my adult life. Boom. All of a sudden, I can't eat without, what would that be?
We see this sometimes where someone might have a small hiatal hernia, right? So a little bit of the stomach comes up into the chest, particularly when you take a deep breath, and it's kind of a come and go thing, right? So it's dynamic. It's not always up in the chest. Sometimes it is, sometimes it isn't. And you may have limited, if any, symptoms. As we age, nothing gets better. There's not a single thing that gets better. We need less sleep, but that's actually because other things are getting worse.
Steve's laughing his head off right now, by the way.
You're so right. You are so right.
Yeah, nothing gets better. So what that means is the things that are keeping things in place, they don't improve, right? So our muscles are not as strong and whatnot. So there's constant pressure. Every single time we take a breath, we create negative pressure, and that puts a little bit of traction onto the esophagus and stomach. And so, it just kind of keeps pulling things up. And then when that hole finally gets to a point where more and more stomach can get up there, it can be something that barely, if at all, bothers you, to something that bothers you, a lot. And I see this all the time. I see patients that, they kind of, I get heartburn once a month, once every so often, I take a Tums, kind of whatever. But then all of a sudden now it's boom, a certain amount of time and it's gotten much worse, and then tends to continue to get worse. It doesn't generally level off a whole lot. Once someone gets on medication, they may find it improves. Even then, a common pattern is that they do great on the medication initially, and then over a period of months to years, they end up having some breakthrough symptoms and, other symptoms as well, because we talked about heartburn, but there are other symptoms. Other symptoms of reflux, we call them, secondary symptoms, not the classic, things like cough. If it refluxes so much, that stuff that comes from the stomach can get into the back of your throat, make you cough. It can make your asthma worse, right? You can get just kind of this sore throat picture. Your voice can be hoarse. These secondary symptoms are things that aren't necessarily treated by antacids or proton pump inhibitors, because it doesn't need to be acid to cause that stuff. So you may not have any heartburn. You may be able to eat and have that comfort, but now all of a sudden you've got this chronic cough or this chronic sore throat, or your voice gets hoarse towards the end of the day.
And the endoscopy shows you whether or not you have the hiatal hernia. Yes.
It's a dynamic thing, but yes, a large or moderate sized hiatal hernia is easily identifiable on endoscopy, as are small. The question is always the significance. Where the rubber meets the road, if you will, is that pH testing. When we can identify that we see acid in the esophagus for a prolonged period of time, that's pretty darn specific and lets us know how bad the reflux is. It's a nice objective way to measure it.
All right, let me ask you this. You mentioned the proton pump inhibitors. That happens to be how I've been controlling it. With Prilosec OTC, you get it at any drugstore. Used to be a prescription, and I had a doctor tell me once, it said, what do you think every one of your cells has in it? A proton pump. So are we doing potential long-term damage by taking these things that are over-the-counter?
That's a great question. The proton pump is basically it's something that sits in our cell membranes, particularly in the stomach, and it literally just makes acid and puts it into the stomach. It's, not unlike under the hood of the car. It's in the hood of your cell, if you want to call it that. And it just makes acid that helps with digestion, right? So the acid in the stomach, along with mechanical kind of turning, if you will, it is part of the digestive process, and then kind of makes it easier for the intestine to then act on it. So you worry that the acid in your stomach, there's been some reports of, increased gut infections and things like that when you neutralize the acid. The other concerns, we know that there's an effect on calcium metabolism, and it's more likely to develop, bone loss down the road the longer you take these things. We know there's a magnesium problem. We don't 100% know what the long-term effect of that is, but we know there's some alteration in the way the magnesium is metabolized. Furthermore, we know that there's an association with chronic kidney disease and and dementia. Now, the cause and effect has not been well established, at least that I've read yet, where we know that because you take proton pump inhibitors, you're likely to get this. We just know there's an association. So association doesn't mean causality. It doesn't mean it causes it. It just means it's associated. But that's where I get a lot of patients, particularly in their sort of, mid-50s. They're like, gosh, I've been on this stuff for 20 years and I don't want kidney disease. I don't want, Alzheimer's or dementia. And so I'd like to get off these medications. So are we walking a dangerous line? Definitely to be continued. But yeah, I think, the more we can get off medication, the better. Again, not a naturopath, but it's interesting. I have a social media, and it's on Instagram, Chris Cottrell, MD. And I've been kind of surprised as I put out some of this information that a lot of holistic people, whether that's diet-based or just holistic type approaches, they actually really like my information because they see this as more of an anatomic correction. Yeah, it's surgery, it's not very natural, but it gets you off these medications long term. So it's kind of been surprising how much people that are into natural cures and natural path type stuff actually sort of appreciate this approach, or the surgical approach to reflux.
Wow, that's amazing and a little bit scary, I got to say, because I remember when this used to be a prescription that we had to come to somebody like you to get, and now it's just out there everywhere, and we don't know this.
Yeah, there's two sides of that coin, because the part of you that just wants people to feel better and you want to help people, I kind of, on one level, I'm okay with it being out there so that people don't have to suffer, right? But the problem is exactly what you're saying, is now you have people that aren't getting any kind of physician advice and get the medication. And so they're missing out on something that could be more serious. As we talk to patients and we listen to what their symptoms actually are, sometimes we uncover stuff with just the history and physical exam that is a little bit more concerning. But, if this has been 20 years and you've been on medication and you've never been scoped, that's someone that needs to be scoped and just make sure there's not any changes. Now, I have this conversation all the time. It's like, look, you've been scoped. Yeah, you've got reflux. You're doing pretty well on your medication. You like your medication. You don't want surgery. You don't have any erosions in your esophagus. I'm not here to tell you that you have to get off the medication or that you have to have surgery. At that point, it's your decision. Do you want to keep taking the medications and know that there's some risk? Is the risk astronomical? Probably not. It's probably not. It's probably relatively safe, but it has some issues. And how long do you want to kind of, I don't want to use the roll of the dice, but how long do you want to be on that medication knowing that there could be an issue? And, if you're 75 years old and you're doing well and you don't have erosions, I don't know. I think that's an appropriate decision. But it becomes your decision as long as we've been scoped and we know that there's not anything that we're missing. And at that point, it's just my job to educate, which is kind of what I always see my job as. My job is to go over what your options are, what the risks and benefits for each option are, and then help you make a decision that works for you.
Dr. Christopher Cottrell from Medical City Frisco, thank you for giving us great information on GERD. Steve?
Thanks, Thomas. And now, as we're looking at the new year and New Year's resolutions, maybe looking at our diet, what we eat, acid reflux, that's something that should be one of those New Year's resolutions. And join us next week for the human side of healthcare.